Good morning, everybody. How you doing today? Everyone's awake? Well, I am. I'm good to be here and here on time. So thank you very much for coming this morning. This is an exciting event that we're putting together. As you all know, we've called it CSI. It's not crime scene investigation, it's cataract surgery investigation. Now, as we were thinking about the theme for this event, actually, we're very fortunate we stuck with CSI because the second choice was actually Roseanne. So I'm actually happy we stuck with CSI. We've got an hour and a bit to talk about some difficult cataract surgery cases. We've got a great team to help us through this here, and we want to get your participation as well as audience. I've got a few housekeeping things to kind of start off with here. But as always, of course, we've got the typical learning objectives. Talk about the potential causes of poorer outcomes or suboptimal outcomes after cataract surgery. Identify the causes and how to manage each of these cases that may result in suboptimal results. We want to thank both the COS and Alcon, who have both co-developed this symposium in an independent manner. This is an accredited activity, so you can count it for your Section 1 credits. And don't forget to do your evaluation on the website as well. So I just want to introduce the scientific committee that was very involved in putting this activity together. I can tell you it was a lot of work, not so much by me, but by these folks up here. Colin Mann, who is right over there wearing a CSI shirt. He's undercover. Sorry, he's undercover. I shouldn't have mentioned where he's undercover in the back, so he's watching everybody. Amandeep Rai, here to my right from Toronto, and Dominique Massicot from Quebec is here as well, both very involved in the scientific committee. These are their disclosures here for the meeting. And then we have our investigative team, and we've made a couple little changes here. We have Rosa Bragamelli, who I think all of you know from Toronto, and Guillermo Rocha, our current president, almost about to give it up soon, from Brandon, Manitoba. Now, Jonathan Solomon, who's our American operative, was called away on a special assignment. So he's not here right now, but we have actually a couple of folks who stepped up here. Both Amandeep and Dominic will be stepping up in his place as important investigators as well. These are some of the investigative teams that I've worked with to try to investigate different devices and things. You can look through that as well. And keep a note that this session is being recorded. Now, we do have some opportunity for some text and for some polls. So please take out your phones. And remember, if you text to 37607, right? Am I getting this right? And you have to write COS 2008.
No, 18.
18, sorry, 2018, sorry. I'm 10 years ago. 2000, just checking everyone's awake here. I'm not obviously.
Ike is forever 39.
Yeah, that makes sense. So text COS 2013, and then
18.
18, why am I saying that? 2018, 2018. And you have to write tell me and then your question, right? So I've never done it before, but that's how you do it. But throughout the session, we'll have some interaction as well about, and some polling questions. So please, interact and get involved in all this as well. So we're going to get started here. We've got 3 cases. They all, I think, have their own little twists and turns. They got their own mysteries as well. So our job, I know it's early in the morning, but our job is to get through these cases, figure out what's happening. There's a long list of suspects and a long list of evidence. We'll get you through all of that as well. And then we'll move to each of our cases as they go along here as well. So we're going to have our special agent, Amandeep Rai.
Sure.
You ready to go?
Present
this case?
Let's do it.
And we've got the whole team here to help you out, my friend.
Thank you.
Thank you.
Welcome, everybody. Thank you for coming out so early. And we're going to jump into our first case, crime scene investigation, cataract surgery investigation, residual sphere after cataract surgery. So here's what we found. We're at the scene of the crime about a month after cataract surgery. Patient walks into your room, and they're not happy. Uncorrected vision at 20/80, corrects at 20/25, -2, plus 0.75, axis 113. Up until that point, we'd have been having a pretty good day, a run of plano results, but this patient kind of makes you think. We'd been doing pretty well for a while, but we needed to figure out what was going on here. So naturally, we went back to the scene of the crime. we're looking for clues here. We're going to put on our detective hats, make sure that we go back, go over everything. But before we do this, are there any ideas from the audience? If you have a patient come in with a refractive surprise, what are some of the things you're thinking about first? Any thoughts? Or else Ike will pick on people.
You guys are part of the team here. Help the investigative team out here. These guys are a little stumped here already. It's first thing in the morning. No. What do you think?
Poor biometry. That's always a good thought. Anyone else? Wrong IOL. Pick the wrong IOL, inserted the wrong IOL.
Good points.
Anyone else?
What else?
Sama, thank you. The previous refractive surgery, that's a good one. So those are obviously very, very top of the mind thoughts. And certainly we lined up the usual suspects. We got a little lineup going on here. And you guys mentioned a number of these, and I think the best thing to do when you have something like this is to slowly work through it. I think we were going to do a text poll here, just to
Oh, there we go.
where do you guys think is the most common cause of residual refractive error after cataract surgery? So we'll take a minute for this.
So remember, to join, you have to text COS2018 to 37607 to join if you haven't joined yet, and then you type in a letter. That make sense? We'll give everyone a couple. I've got 13 people have figured it out. That's probably the hardest thing to figure out, for me at least.
Harder than the Royal College exam.
Seriously.
You can say that now.
All right, not everyone has their phones, it looks like. That's pretty good. 27, what are we going to go till?
30.
30.
We're
Okay.
almost there.
Go to 30. Okay, let's see what we got here.
Oh, did we get the results after?
We get results
Okay,
after.
Okay.
we'll go back to the results after. Let's figure out what's happening first. So clue number one. So we're going to go through a series of CSI clues. And the first thing, naturally, when you have this patient, is you're going to look at them at the slit lamp. So that's what we found.
So what lens did you use?
Well, we used a single piece acrylic aspheric IOL,
And was it well centered and completely in the bag?
just like you taught me. One piece IOL in the bag every time, 360 overlap.
Are you sure the correct one was chosen?
So that's a good question. So after looking at the slit lamp, the first thing I did was I went back and reviewed my biometry, reviewed my operative report, and so you can see there, that's the 360 rexus overlap. But we went back to our operative report, double-checked that we inserted the correct IOL that we had selected, and went through our biometry, and we would have picked the same lens again.
So, Agent, anyone can look at the biometry and pick the lens that the biometry says, but what about the ocular surface?
You know, I had a feeling you might say that. And so, you're right. I mean, we're probably underestimating and undertreating dry eye in our cataract population, and there's good evidence to support this. But I don't really know if that was the issue here. So we went ahead and reviewed the topography of this patient, and this was the left eye, keep in mind. So we're looking at the left eye print out there, and there's no evidence of any significant dry eye. And the other thing, to get back to Sama's point, there's no evidence of any previous refractive surgery either. So that's an important consideration here. So we're back kind of to our lineup of the usual suspects. We've ruled out some of the common causes, dry eye, inaccurate biometry. We double-checked our IOL. We didn't hit the wrong IOL. So do we have any other thoughts from the audience? What else could this be? Mislabeled IOL. Mm-hmm. And so that's always a difficult one to prove, right? Any thoughts on how you might prove that? Right. Well, you'd have to take the lens out, but then put the same lens power back in. you definitely could do intraoperative aura. Or the other thing I've seen done is you can actually do optical biometry after the fact and measure the lens thickness. And Warren Hill has a table, and so if you can even send him your data, and he has a table where you can send in your lens thickness, and he can send you back approximately what IOL power that translates into, because the higher the power, there's a slight increase in thickness of the IOL. So that's a very good thought, and very difficult to prove. So let's go on to our second clue here. And so that's actually what we did, right? So we do have post-operative biometry here. So the right eye is still phakic, the left eye is pseudophakic. And does anyone want to comment on sort of the some of the parameters on this printout comparing the two eyes? Absolutely. So if you didn't hear that, the AC depth is larger in the left eye because they're pseudophakic. That's to be expected at this point. The other interesting thing is they're both longer eyes than average, but there's symmetry between the two eyes, both longer than average, and the Ks are both flatter than average. Both risk factors for a refractive surprise after surgery. But again, we'd already ruled out previous LASIK or PRK. Sorry? Absolutely. Good thought.
So I'm just wondering, I mean, your Ks are a little flat.
Yes.
So what type of error do we typically see with some of the older formulas with flatter Ks? Anybody know? Flatter Ks usually assume that the lens is going to sit closer to the cornea or farther to the cornea?
Closer.
Closer to the cornea. So typically, the formulas would knock off some power, and you may get a hyperopic surprise, which didn't happen in this case, but that's kind of what sometimes we worry about, particularly some of the two variable formulas.
So let's recap. Let's see where we are now. So far, we've double-checked the IOL. We made sure that it's in the bag, that the correct IOL was implanted. We had good rexus overlap. We had minimal ocular surface disease. And we don't have any previous LASIK or PRK. Good thought. Hold that thought. And so I guess
Did
at
you
this
plant somebody in the audience?
he's not a plant. But the rest of the audience can't hear him, so he's good. So at this point, I mean, one of the first things we all do with anybody who's not whose vision is not as we expect is get a MAC OCT. And so we did that, and that's normal. And we've already looked at the corneal topography as well. Anything else you might want to do on exam with this patient?
I think so, or something.
Look at the fundus, right? So you want to make sure there's nothing else going on. And so here's the optos pictures. I mean, a little bit of the eyelashes there, but it's a myopic fundus, but within normal, just as you would expect. And so we're kind of back left with our usual suspects. And we're starting to knock things off, but we're still not quite there yet. So let's give you clue number 3.
So the eye well looks vaulted anteriorly a little bit, doesn't it?
It does. It does. And when your IOL is sitting a little bit more anteriorly than you expect, there's a number of things that could be causing this. So before we get into that, we actually have a video as well of this.
Yeah, but you're here in Toronto. You don't have a UBM?
Of course, we have a UBM. Right. So for those who don't know, the UBM was invented by the late Chuck Pavlin in Toronto. So we'd be remiss to not get one. And so that's clue.
Did everyone see the clue there? What I think. There's an optical gap between the lens and that posterior capsule there, so that may explain why Special Agent Bragamelli pointed it out.
That was the AC depth.
That's the AC.
Yes.
It didn't.
So Agent Ahmed Like, what could this be? Like, what could be going on here? What's happening with this IOL?
Well, I mean, the lens is vaulted anteriorly, so it could be a variety of things, especially, of course, if it was a three-piece lens, it could be placed upside down. If the lens was in the sulcus, as we were talking about, it could be anteriorly and vaulted forward as well, a small eye, for example. We have to think about posterior segment issues, uveal effusions, malignant glaucoma. This patient's a long eye, maybe not as risk for malignant glaucoma, but I'd be thinking about that as well. And I think what we saw in the slit lamp is certainly a concern for capsular block syndrome, which surprisingly is actually not too uncommon, where there's typically retained viscoelastic and aqueous buildup behind the lens, pushing the lens forward, and we typically see that optical gap between the posterior capsule and the IOL. So those are some of the things that I'd be thinking about, along maybe with loose zonules that may cause the lens to move forward.
Absolutely. So, I mean, we've kind of gone through the differential there. The only other thing I might add is something like a suprachoroidal hemorrhage pushing the lens forward, but we saw the fundus already. The fundus looked fine, and the AC was deep. So we're kind of putting it together. Cataract surgery was uneventful. The IOL was well placed, and we've sort of brought all of our clues together. We've seen our slit lamp photos. We've seen our corneal topography. We reviewed our IOL calculations. That's probably the first two things any of us would do when faced with a refractive error, for refractive surprise. And we saw that very important clue on slit lamp video, and then the UBM picture, which I'm going to bring back up here. And so again, on the UBM, you can see that pocket sitting behind the IOL there, and then you're seeing actually the reflection of the IOL in case you're wondering what's happening down below. And so this is, as Special Agent Ahmed has accurately described, capsular block syndrome.
Just one question. I mean, if you go back,
Yes.
you made a comment before about the temporal wound.
Yes.
Is that relevant at all in your case?
Well, that gave you a little bit of that sill, right? Because you have the temporal wound, which is causing flattening in that axis.
Okay.
And afterwards, you did end up having a little bit of with the rule cylinder, consistent with that.
Okay.
So capsular block syndrome is a known entity, and essentially, most frequently, what you have is retained viscoelastic behind the IOL, pushing the IOL anteriorly, resulting in a myopic shift. This is not something that typically goes away on its own, but it is easily treated with a YAG capsulotomy.
And when is a good timing to do it?
So that's a good question. And I'm going to throw it up to our special agents. Any thoughts on timing? Because this patient's going to be unhappy until we fix this.
But Agent Rai, I have a question though. Do we have to laser the posterior capsule? I mean, it's kind of early to do that. Are there any other options to release that aqueous if we can?
I mean, you could go back in there, right? I mean, it would be a very quick procedure to do a quick IA.
What if we can get the pupil really dilated? How about lasering the anterior capsule beyond the optic of the lens?
Yeah, that would release it too.
That might be an option just to protect if you're worried about doing an early laser posterior capsulotomy. Not that it's a big issue, but.
I usually like to wait at least 6 weeks before I do a posterior capsulotomy, because I think there's some studies out there, I can't quote the exact studies, but before 6 weeks, it's almost like breaking capsule, that your CME risk is quite high if you do a YAG capsulotomy before 6 weeks. But if you wait till after 6 weeks, then your risks are just like if you waited a year or 2 years. But there are risks with posterior capsulotomy, so I like your idea, Ike, of if you can get the pupil widely dilated and do an anterior capsulotomy, you don't transmit the energy like you would to the anterior hyaloid face, and getting some of that fluid to come forward. If it's fluid, if it's viscoelastic, would it come over the optic?
In my experience, it's usually pretty liquefied. It hydrates pretty quickly.
Yeah.
So the viscoelastic
Would
agent.
you have any fear of, by doing that YAG, the lens tilting now and inducing an astigmatism?
It's a good question. So I think if you can do it, get the pupil really dilated and try to leave the capsular excess intact and go beyond that. So basically you have a small little opening.
Okay, I see what you're
So it's
saying.
just a little opening on the side and the rexus is still intact for that reason you mentioned.
Okay.
It's a thought. Well, I think that's a good question. I think they can resolve, especially if they're small, if it's a small amount. And that's why I think, as we heard, waiting for a few weeks, I think is reasonable to do that. Plus, of course, the eye settles down a bit. But if it's still present after a month or 6 weeks, I think it's probably not going to resolve on its own. It's amazing how often these are are persistent. And this is an early case.
Right.
There have been many reports of late onset capsular block syndrome with liquefied SOM rings and material that basically builds up. And that's typically milky. Treated the same way, but I think waiting a bit is reasonable, yeah, I would agree.
And is there a risk of pupillary block in that case?
I think it's a good question. Yeah, I mean, if the lens is really vaulted forward, then absolutely, you got to watch for that. The angle sometimes can get closed. You can get elevated pressure from that as well. So then you're forced to do something earlier, of course, in that situation. Yeah.
And I guess the other thing is you can always discuss with your patient that you have a cause for this, and that'll buy you some time as well, right? I mean, if they come back and they're unhappy, but they know that you know what's going on and you're buying time for a reason, they're more likely to accept that. So in our patient, we had a very good outcome. A YAG capsulotomy was performed, and the uncorrected vision was 20/25, and this patient went on to live happily ever after.
So how long after the patient presented was the capsulotomy done?
So this was around the 1 month period.
1 month.
Essentially because, I mean, that's when this all started for our case here.
Well, I mean, Agent Rai, I think you did an amazing job filling in for Agent Solomon. He'll be very proud of your work here, and the team, I think, came together. These are not always routine cases, and they're difficult. That's why we have the CSI team here, award-winning TV show here that's on stage here. So I was really, really impressed. It's going to be pretty hard, I think, to kind of continue the success rate with the next couple cases, but we'll try. We'll try.